Kidney stones are a common condition that can cause significant discomfort, but there are many myths and misconceptions about them. Here are some common myths about kidney stones and the facts that debunk them. 1. Myth: only adults can get kidney stones. Fact: while kidney stones are more common in adults, they can occur at any age, including in children and teenagers. The reported annual incidence of kidney stones in children in the United States was estimated to be over 200,000 cases per year in 2011. Similarly, over 9,000 cases were also reported in Israel in 2012, which rose from 5,000 cases in 1995. Main risk factors for kidney stones in children are metabolic. The most common disorder is high uric acid concentrations in the urine, followed by high oxalate concentrations. 3. Myth: all kidney stones are extremely painful. Fact: not all kidney stones cause pain. Most kidney stones do not cause any pain and are found incidentally during some imaging studies. A study of 107 patients with asymptomatic stones, for example, found that almost 70% remained symptom-free during the 31 months of follow-up. Symptoms may develop when stones initially pass from the kidney into the ureter or the kidney pipe. The pain can be so intense that it requires intravenous painkillers. The pain typically develops in waves or paroxysms. These usually last 20 to 60 minutes. Pain is thought to occur primarily from urinary obstruction with distension of the kidney capsule. 4. Myth: once you have a kidney stone, you'll always have them. Fact: while having one kidney stone increases your risk of developing another, changes in diet and lifestyle or medical management can significantly reduce the chances of recurrence. In one prospective trial, 199 patients with a first calcium oxalate stone were randomly assigned either to no therapy or to a recommendation of a high fluid intake to produce at least 2 liters of urine per day. At 5 years, the incidence of new stone formation was significantly lower in the treated patients than in those in the control group, 12 versus 27%. 5. Myth: calcium-rich foods cause kidney stones. Fact: dietary calcium does not usually cause kidney stones and can actually help prevent certain types of stones by binding to oxalates in the digestive system and preventing their absorption. We generally encourage patients to consume several servings of dairy or other calcium-rich foods to reach 800 to 1,000 milligrams per day. For example, a cup of milk and 3 slices of soft cheese a day. Restricting dietary calcium intake is not generally recommended unless it is excessive, more than 1,200 milligrams per day. The ability to help prevent new stone formation with adequate calcium intake was shown in part by a 5-year randomized trial that compared 2 diets among males with idiopathic hypercalciuria and recurrent calcium oxalate stones. In this trial, 120 such males were randomly assigned to either an adequate calcium diet, 1,200 milligrams per day, or a low calcium diet, 400 milligrams per day. At 5 years, the group assigned to the adequate calcium had a lower risk of stone recurrence. 6. Myth: only people with poor diets get kidney stones. Fact: while diet plays a role, other factors like genetics, dehydration, and certain medical conditions can also contribute to kidney stone formation. Further support for a genetic link with the development of kidney stones was provided by a twin study from the United States. Concordance rates for a history of kidney stones were compared in identical and non-identical twins among approximately 7,500 twin pairs. The concordance rate in identical twins was significantly greater at 32.4% than the rate in non-identical twins at 17.3%, consistent with a genetic influence. The heritability of the risk for stones was 56%. 7. Myth: surgery is the only treatment for kidney stones. Fact: many kidney stones pass naturally with time and hydration. In some cases, medications or less invasive treatments like shockwave lithotripsy (SWL) can be used. For ureteric stones, if they are around 6 millimeters or less and not very painful, a trial of passage is often offered if they are 7 millimeters or larger, or causing symptoms. Treatment is usually offered with either shockwave if the stones are at the upper part of the ureter, and an operation to laser the stone from the inside with a camera called a ureteroscopy if the stones are at any part of the ureter. For kidney stones, if they are 5 millimeters or less, options include surveillance with regular scans to assess for any potential for rapid growth, or treatment with either shockwave or ureteroscopy and laser. If the stones are over 5 millimeters and the patient is generally fit, treatment is often recommended, Options include shockwave or ureteroscopy, depending on the patient wishes. The success rate of shockwave is around 70% overall, compared to 85% for ureteroscopy and laser. If the stone is larger than 2 centimeters, which is also called a staghorn stone when branching into the multiple compartments of the kidney, another operation called a PCNL is considered. The kidney is accessed through the skin of the back, and large instruments are used to destroy the stone with ultrasound shockwaves. 8 myth. All kidney stones are the same. Fact. Kidney stones come in several types. The most common types are in order of frequency. Calcium oxalate 70 to 80%, calcium phosphate 15%, uric acid 8%, cystin 1 to 2%, struvite 1%, miscellaneous less than 1%. 9 myth. Drinking cranberry juice prevents kidney stones. Fact. While cranberry juice may help prevent urinary tract infections, its role in kidney stone prevention is uncertain. There have been no studies correlating consumption of cranberry juice to actual stone formation. 10 myth. Only unhealthy people get kidney stones. Fact. Kidney stones can affect anyone, regardless of overall health. Factors like genetics, climate, and even certain medications can play a role. Examples of medications that increase the risk of kidney stones. Long-term steroids can increase the risk of calcium oxalate and calcium phosphate stones by raising urine calcium. Laxatives may increase the risk of calcium oxalate stones by inducing a malabsorptive state and thereby increasing urine oxalate. Loop diuretics, for example furosemide, may increase the risk of calcium oxalate and calcium phosphate stones by raising urine calcium. By understanding the facts about kidney stones, individuals can take better preventive measures and seek appropriate treatment if needed. This is the end of the video. I hope you found it educational and informative. Please consider liking, sharing, and subscribing to the channel to help its growth. Thank you for watching and see you in the next video.